سيكوليمود selective sphingosine 1 phosphate receptor modulator. Relapsing remitting MS is characterized by peripherally driven inflammation dominate. Early signs of neurodegeneration may be subtle and masked by compensatory repair mechanisms. Targeting early inflammation provides an opportunity to improve treatment outcome by preventing CNS damage. Secondary progressive MS. As MS progresses, peripheral inflammation declines, central inflammation and neurodegeneration dominate. Failure of compensatory repair mechanisms. With disease progression, disability increases with diminished mobility, cognitive impairment, resulting in loss of independence. Early treatment of CNS inflammation with effective disease-modifying therapy may preserve brain function. Patients remain their independence for quite a long time. Gray matter atrophy increased at secondary progressive MS onset. Gray matter atrophy has 3 to 4-fold increase at relapsing remitting onset. Gray matter atrophy has 14-fold increase at secondary progressive MS onset. Gray matter atrophy steeply increases upon secondary progressive MS onset. It drives irreversible accumulation of disability and contributes to cognitive impairment. Cortical demyelination is increased in MS compared with relapsing remitting MS. In relapsing remitting MS, the median cortical lesion area is 2 to 3%. Remyelination is extensive in early MS. In secondary progressive MS, median cortical lesion area is 11 to 13%, especially in the deep gray matter and the cortical lesion. Then there is failure of repair mechanisms. The pathological features of MS or secondary progressive MS, this has been summarized as follows. Number 1, receding of the blood-brain barrier. 2, CNS compartmentalized inflammation leading to driving neurodegeneration and accrual. The word accrual means accumulation of disability. Gray matter atrophy, gray matter demyelination, thalamic atrophy, focal white matter damage, slow expansion of existing lesion, lymphoid-like meningeal follicles with features of tertiary lymphoid structure that may lead to widespread demyelination. Then reduced remyelination, smoldering, inactive, and shadow plaques, diffuse neurodegeneration in gray matter and normally appearing white matter of the brain and spinal cord due to microglial activation in addition to activation of brain-resident immune cells. Finally, the neuroaxonal loss due to diffuse inflammation. Silent progression. This is a very important term, silent progression. The process underlying secondary progressive MS begins far earlier, much earlier than recognized, with both inflammation and neurodegeneration occurring throughout the disease spectrum. Insidious progression accumulates in many early relapsing remitting MS patients who remain classified as relapsing remitting MS. So, it's important to recognize silent progression during relapsing remitting MS. What's meant by silent progression? Long-term worsening is common in relapsing MS patients. Is largely independent of relapse, the so-called PIRA activity, and is associated with accelerated brain atrophy. Silent progression refers to the insidious disability that accumulates in many patients who satisfy traditional criteria for relapsing remitting MS. Relapses are associated with short-term but not confirmed or long-term disability worsening. The appearance of silent progression during relapsing MS and its association with brain atrophy suggests that the same process that underlies secondary progressive MS likely begins much earlier than is generally recognized before. A unitary view of MS biology with both focal and diffuse tissue destructive components and with both inflammation and neurodegeneration occurring throughout the disease spectrum. Markers, what are the markers of neurodegeneration, are useful in identifying patients with silent progression. Number 1, brain atrophy. Number 2, spinal cord imaging. Number 3, optic coherence tomography. And number 4, serum neurofilament light chains. no clear clinical imaging, immunologic, or pathologic criteria to determine the transition point when relapsing remitting MS converts to second progressive MS. Second progressive MS is generally diagnosed retrospectively by a history of gradual worsening after an initial relapsing disease course, with or without acute exacerbation during the progressive course. So one term I mentioned, the word here, silent progression. The second important word, diagnosis of second progression, is often played in clinical practice, the so-called field of diagnostic uncertainty. The time that elapses, or the time period between the last visit with definitive second relapsing remitting MS diagnosis till the first visit with definitive second progressive MS diagnosis, is 4 years. The time period between the first visit with a suggestion of progression and the first visit with definitive second progressive MS diagnosis is 3 years. This is called period of diagnostic uncertainty. 70% of patients had a period of diagnostic uncertainty. The transition from relapsing remitting MS to second progressive MS is gradual, with no clear-cut marker to define transition. Disability accumulated between progression, onset progression, and definitive diagnosis. So, 84.8% of patients had onset of progression at EDSS less than or equal to 2. 75 patients has received diagnosis of at EDSS greater than or equal to 6. 77% of patients had progression recognized at EDSS less than or equal to 3. Not all disabilities are visible. Most clinicians would not consider patients with relapsing MS with a low level of disability to have second progressive MS, in which accumulation of disability occurs independently of relapse activity, despite mounting data, important data, that patients with relapsing MS frequently worsen over time. Now, what are the patient and the physician report about second progression? Regarding the patient, they are very concerned about mobility and self-care. Regarding the physician, they are very concerned about EDSS, age, and disease activity. This slide is extremely important. How can you demarcate transition from second progressive MS? In transitioning patient, here the diagnosis is non-motoric. The EDSS is greater than or equal to 3. This is the so-called PIRA, progression independent relapse. Second progressive MS is defined by a progressive increase in disability of at least 3 months duration, independent of relapse. Confirmed disability progression as measured by EDSS or greater than 20% progression in time 25 foot walk or 9-hole peak test. 2. EDSS score 3. 3. Cognitive impairment as assessed by simple digit modalities test. 4. Naive or previous disease-modifying therapy. 5. Most commonly reported symptoms in progression. 1. Cognitive symptoms, 45%. Bowel and bladder symptoms, 57%. Ambulatory and motor symptoms, 87%. Coordination and balance, 89%. This has got an impact on the patient's daily life. Coming to the next slide, the next half of the slide, patient with active second progressive MS. This is motoric. In contradistinction to the first one, which is non-motoric. The EDSS is greater than or equal to 4. 1 point EDSS score increase with an EDSS score of 5.5 or less, or 0.5 point EDSS score increase with an EDSS score of at least 6 in the absence of relapse. 2. An EDSS score of at least 4 at onset. 3. Pyramidal function system score at least 2. 5. Confirmed progression over at least 3 months. Accuracy of this definition is 87%. It enabled the diagnosis of second progressive MS 3 years earlier than the diagnostic date assigned by the treating physician. What are the limitations of the EDS? This is simple, I will not say, but just I want you to know something. The EDSS has good specificity. Most patients diagnosed have progressive disease, but poor sensitivity, fail to identify non-motoric progression like cognition, fatigue, pain, sexual dysfunction, etc. What are the factors prognostic for evolution of second breast MS? This is very important slide. The factors prognostic for the evolution of second breast MS. 1. Old age at MS onset. 2. Male sex. 3. Early, high relapse frequency, longer disease duration, higher baseline EDSS score, greater early increase in EDSS score, higher T2 lesion burden, spinal cord involvement, lower burden, lower brain volume, and the current age. Cognitive impairment as a predictor of disease progression. Cognitive impairment predicts 1. Disability progression, 2. Transition to second breast MS, 3. Cortical thinning in patients with relapsing remitting MS. Cognitive impairment is common among all people living with second breast MS and is often underdiagnosed. Overall prevalence of cognitive impairment across MS subgroups. We find that in clinical isolated syndrome, the cognitive impairment is 24.5%. In relapsing remitting MS, it is 35.5%. In second breast MS, it is 79.5%. Compare the difference. Now, impairment of cognitive domains in second breast MS. 37% of patients showed impairment in at least 2 of the 3 important domains. That's to say, attention and processing speed lost in 55%, executive function lost in 31%, memory lost in 26%. There are 4 reasons, and that's very important. I always stress upon my colleagues during MS session. If you find a patient coming by cognition early, be sure is going to be second breast very early. There are 4 reasons why monitoring cognition in MS patients is key. 1. To provide a baseline for diagnosis and prognosis. 2. To flag cognitive relapses. 3. To monitor progression where cognitive decline could signal MS progression. 4. Better profiling of the physical and emotional risks of the patient. Diagnosis of second breast MS. How can you diagnose it? It's retrospective, based on the patient history of worsening following an initial relapsing remitting course. 1. Deterioration independent of relapse for 6 months, following an initial relapsing course. 2. Accumulation of minimal level of disability. 3. Initial symptom of progressive MS manifest on taxing the nervous system. يعني ايه taxing the nervous system؟ لما تجهد الجهاز العصبي، يعني تقول له اطلع سلم، تقول له شيل حاجه ثقيله. كلمه taxing the nervous system انجليزي قوي، معناها انك بتجهد الجهاز العصبي. طيب. Initial symptom of progressive MS manifest on taxing. خلاص. Then long-term worsening may occur in patients with relapsing remitting MS, independent of relapse, so-called PIRA. Silent progression associated with accelerated brain uptake. The most important item with silent progression is association with brain uptake. 5. A period of diagnostic uncertainty. 3 years characterize the clinical transition from relapsing remitting MS to second breast MS. Potential reasons for delay. What is the cause of delay in the diagnosis of relapse of secondary progressive MS? Number 1, indicator of secondary progressive MS may be subtle. 2, patient may report worsening of their condition, but the neurological examination reveals little. 3, many of the clinical features of secondary progressive MS are observed during normal age. So, to make the long story short, secondary progressive MS, number 1, silent progression. 2, accrual of minimal disability. 3, symptoms of progression on taxing the nervous system. 4, long-term worsening and relapsing remitting MS independent of relapse. 5, period of diagnostic uncertainty. 6, silent progression. Diagnostic remarks. This is very important slide. Diagnostic biomarker. Motoric. The EDSS, the 9-hole peg test, and T25 foot walk. Then MS functional composite, which includes time 25 foot walk, 9-hole peg test, and the FASAD, the so-called paced auditory serial addition test. 2. Cognitive assessment. It includes simple digit modalities test. 2. Brief international cognitive assessment for MS. 3. Paced auditory serial addition test. 4. California verbal learning test. 5. Brief visual-spatial memory test. 3. MRI biomarkers include gray matter atrophy, spinal cord damage, iron rim lesion. Iron rim lesion. What's iron rim lesion? A slow expanding lesion with a rim of iron-laden microglia or macrophage. Patients with 4 or more iron rim lesion develop motor and cognitive disabilities at a younger age, are 1 to 6 times more likely to be diagnosed with progressive MS than those without. So, if you look to the MRI, extremely important to diagnose iron rim lesion. Then the so-called translocator protein PET. What's translocator? Translocator protein is a mitochondrial molecule. This molecule is upregulated upon myoglobin activation. It's a good marker of progression. It's not available in Egypt, but available outside. Number 4, the MS ProDiscuss tool. This is an algorithm to facilitate dialogue between physician and people with MS. Finally, the very advanced technique of the so-called wearable accelerometer. That's an apparatus or device that the patient is going to have to monitor the step count activity. We call this wearable accelerometer. What to target for optimum cyclic rhythm management? Treatment of cyclic rhythm MS is very problematic. Why? Number 1, in the transitional phase, the disease process becomes gradually less amenable to disease-modifying therapy because of A, declining contribution of the prevalent mechanism of immune cell activation. B, the decrease of immune cell migration to the CNS. C, the formation of lymphoid aggregates. 2, late diagnosis. 3, advanced CSS damage. 4, ineffective drugs. 5, difficult in determining the clinical benefit of the drug. These are the causes why treatment of cyclic MS is extremely difficult and problematic, and most of the people escape from it. Treatment approved in relapsing remitting MS. Treatments approved in relapsing remitting MS do not consistently slow disability progression in cyclic MS. Many trials have been done. Number 1, interferon beta 1b negative study. Interferon beta 1a negative. Natalizumab negative. Dimethyl fumarate, not dimethyl fumarate, is negative still. Historically, no treatment approved for relapsing MS has shown consistent slowing of disability progression in cyclic MS using EDSS score. Cepolimod reduced the risk of 3 months confirmed disability progression by 21% with dual mode of action. Number 1, effect on peripherally mediated inflammation that drives the reduction in disease activity. 2, direct anti-inflammatory and pro-myelination effects on the CNS that target CNS compartmentalized inflammation drive the slowing of gray matter. 𝐬𝐩𝐸 1-phosphate receptor modulator in multiple sclerosis. As you know that we have 𝐬𝐸 1-phosphate receptor 1, 2, 3, 4, 5. Cepolimod works on both except 2. Cepolimod and ozanimod works on 1 and 5. Poncimod works only on 1. Cepolimod is a selective 𝐬𝐸 1-phosphate receptor 1 and 5 modulator with a dual mode of action, targeting both inflammation and neurodegeneration. It will work on down modulating the 𝐬𝐸 1-phosphate receptor 1 and activating 1 𝐬𝐸 phosphate receptor 5. One down regulating and the other one is activating. Let us speak about 𝐬𝐸 1-phosphate receptor 1, which is present on lymphocytes, astrocytes, microglia, endothelial cells, cardiomyocytes, and smooth muscle cells. What is the result of this? Number 1, reduction of lymphocyte egress from the lymph nodes. 2, regulation of endothelial function. 3, reduction of heart rate. This by down modulating the 𝐬𝐸 1-phosphate receptor 1 on lymphocyte, cepolimod reduces lymphocyte egress from the lymph nodes, thereby limiting the number of circulating lymphocytes enter the CNS that may cause inflammation. The other side, the central nervous system. it is 𝐬𝐩 phosphate receptor 5. It's present in the central nervous system on oligodendrocytes and natural killer cells. What is the result of its stimulation? Regulation of oligodendrocyte maturation. Ceponimod is able to penetrate the blood-brain barrier to limit central inflammation and promote CNS repair as shown in animal studies. Very important and very advanced and recent. Why? Because it has been said before many times that small molecules are all can pass the blood-brain barrier. This could be wrong. Because, for example, teriflunomide, now recently they say it does not cross the blood-brain barrier. Those disease-modifying therapies which cross the blood-brain barrier include cladribine, that's mavinclad, fingolimod, ceponimod, and ozanimod. But fingolimod, there is one word. You must know that fingolimod is a prodrug. In order to be active, it must be phosphorylated. And that's why fingolimod is activated into the active form fingolimod phosphate. Fingolimod phosphate does not cross the blood-brain barrier. New information. Number 2, there is a less dose amount of fingolimod which pass to the CNS are prodrug. In order to be active, must be phosphorylated. There is no kinase inside the CNS. There are two different points regarding fingolimod. Affinity of 𝐬𝐩 phosphate receptor derivative of 𝐬𝐩 phosphate receptor using the so-called EC50. What's EC50? How much of the drug is needed to achieve 50% of the maximum response? The more potent the drug, the lower the EC50. If you observe here, the EC50 for ceponimod is 0.39 for 𝐬𝐩 phosphate receptor 1 and 0.98 for 𝐬𝐩 phosphate receptor 5. This shows you how selective it is. Ceponimod mode of action is 𝐻+S. Peripheral immune system inhibits egress of lymphocytes from the lymph node. Central nervous system crosses the blood-brain barrier, favors remyelination and repair. Possible anti-inflammatory effect in the CNS. Ceponimod reduced sustained progression to EDSS greater than or equal to 7, the so-called wheelchair, versus placebo by 51%. Ceponimod is predicted to extend the median time to wheelchair by 7.9 years versus placebo in active second. احنا بنبقى في عرض يوم. فلو انا جات لي دواء يقدر يخليني 8 سنين مفيش ويلشير يبقى احسن. The bottom line. Number 1, as MS progresses, peripheral mediated inflammation pathology declines, while central inflammation and neurodegeneration become more prominent. 2, the CNS-based pathology of secondary MS may explain the limited success of most of the modifying therapy used in relapsing MS. 3, silent progression refers to the long-term worsening independent of relapse activity, which with accelerated brain atrophy. 4, a period of diagnostic uncertainty, 3 years, characterizes the clinical transition from relapsing remitting MS to secondary MS. 4, no clear clinical imaging, immunologic, or pathological criteria to determine the transition from relapsing remitting MS to secondary MS. 5, the EDSS has a good specificity progression, but poor sensitivity to identify non-motoric progression, for example, fatigue, sexual dysfunction, pain, cognition. 6, biomarkers to identify the transition from relapsing MS to secondary MS include motoric, cognitive assessment, MRI biomarker, and the MS ProDiscuss tool. 6 or 7, ceponimod has a high affinity for 𝐬𝐩 phosphate receptor 1, functional antagonist, and 5, functional agonist, with a dual mode of action. Take care that I want you to observe that when I mention ceponimod, it acts on 𝐬𝐩 phosphate receptor 1 and 5. On 1, it is antagonist, functional. On 5, it is agonist. With a dual mode of action, preferably it inhibits the egress of lymphocytes from the lymph node. Centrally, it targets the pathological process that drive disability progression in secondary MS with neuroprotective effects. Finally, ceponimod is the first and the only disease-modifying therapy to delay disability progression and cognitive decline in secondary MS. And thank you so much.